Good morning, everybody. Welcome to Pediatric Grand Rounds. Thanks so much to all of you who are here in the room with us and all of you who are here online. And I have the pleasure of introducing Dr. Travis Piester, who's an associate professor in the Department of Pediatrics here at the University of Washington and the director of the Pancreas Program and the director of Endoscopy here at Seattle Children's. After completing pediatric GI fellowship at Stanford, he completed a fourth-year fellowship in advanced and therapeutic endoscopy with a focus on pediatric care at Baylor College of Medicine. And in February 2023, he became director of the Pancreas Program and director of endoscopy here at Seattle Children's Hospital. In addition, he also works with our University of Washington colleagues in interventional endoscopy, caring for adult patients. So excited to learn from you today. Welcome, Dr. Piester.
All right, thanks everyone for being here and joining online. I'd like to thank the Grand Rounds Committee and Dr. Suzanne Mazur for the invitation to speak today. I also like to thank Dr. Walker Harding from the Department of Pediatrics and Dr. Sue from my division for promoting our practice of endoscopy here at the University of Washington and Seattle Children's. So today, I'm going to speak on pediatric interventional endoscopy at Seattle Children's, and the title of my talk will be Endobariatrics and the Future of Pediatric Endoscopy. So we'll start off with some disclosures. I'm a consultant for ConMed, but I won't be discussing any of their products, and it won't affect any of the education provided. And first, let's outline what we want to achieve today with an agenda and objectives. The talk is really broken into three parts. The first part is really an introduction to interventional endoscopy in pediatrics with some history and how I was involved and how I got involved in pediatric interventional endoscopy. And I'd like the audience to understand what types of procedures a pediatric interventional endoscopist performs with that. The second part of the talk would be focused on our current practice, and really this is going to be through case-based examples, and I've chosen some examples that really highlight where we are in the frontier of bringing in new procedures to pediatric medicine, really oftentimes borrowing from our adult colleagues, but applying them to pediatric disease. And with this, I'd like the audience to have some exposure to some of these recently introduced procedures at Seattle Children's. And then kind of the meat and potatoes, the final part is kind of the future of interventional endoscopy in pediatrics, and where I've chosen to focus, which is in endobariatrics, which is where I'd like the audience to be introduced to endobariatrics, kind of what it is, and its role within a multidisciplinary weight management program. So to get started, let's kind of look at what is interventional endoscopy. And really, interventional endoscopy is a lot of things, but it's either called advanced endoscopy, interventional endoscopy, but it really includes the endoscopic procedures that are beyond the typical training that one receives in their 3-year adult or pediatric GI fellowship. So that can have a lot of different definitions. It really often will center around pancreatobiliary care with things like ERCP or endoscopic retrograde cholangiopancreatography. That's where we enter into the bile ducts and the pancreatic ducts from the small intestine. And it'll also include some endoscopic ultrasound procedures where we can examine and intervene organs surrounding the GI tract. But beyond pancreatobiliary, there's quite a bit of procedures that are non-pancreatobiliary that also fit into interventional endoscopy's world. And those are things like deep balloon enteroscopy, complex polypectomy, stenting, dilation, closing fistulars, placing tubes, all kinds of stuff. And then really where we are right now is at Seattle Children's, we've included almost all of these into our practice, but there's still a future out there, and where we are focusing is in the endobariatric space for tomorrow. So then beyond some just kind of definitions, I'd like to give a little bit of history of where we're coming from with interventional endoscopy. And it really starts with adults in the 1960s and early 70s doing the first ERCP, which is really the first procedure where interventional endoscopy is centered. And the adults start doing that in the 70s. And then in the mid-70s, Dr. Jerome Way in New York did the first ERCP in an infant. And then in the early 80s, Peter Cotton did a case series of pediatric ERCP. And it wasn't until the 1990s where the pediatricians really became more involved. And that's when they developed the first pediatric duodenoscope, which is here on the right. and a much smaller duodenoscope, which is the scope we use for ERCP, a lot bigger than the adult scopes that you see on the left. They developed pediatric endoscopic ultrasound, and the first pediatrician-trained pediatric interventional endoscopist came on the scene in Dr. Fox in Boston and Dr. Gilger in Houston. And really, I used to think I was a pretty young physician, but it seems like the 1990s are pretty far in the rearview mirror now. So there wasn't a lot of people that got into this space over the next 20 years. There's only a handful of people. And I pick the history up here where I became more involved, and really this is something that clarified the picture of what interventional endoscopy was just a handful of years ago. So recent history, the group at Stanford gives a survey to all the interventional endoscopists throughout the country and their divisions. And those divisions, they're asked, how do they feel about their arrangements for performing pediatric endoscopy? And unfortunately, about 60 or over 60% of pediatric GI divisions were not satisfied, did not feel it was an adequate arrangement for pediatric ERCP. And so it really highlights a dissatisfaction of how pediatric patients were treated in this space. So there are a couple of big issues. I think the big one is a barrier to care, and Seattle Children's is a good illustration of this, where you have a pediatric hospital and you have pediatric GI doctors, but you have a pediatric patient that needs interventional endoscopy. Over here at an adult hospital, you have advanced endoscopy services, you have adult advanced endoscopy or interventional endoscopy physicians, but there's barriers. These barriers can be location, obviously. They can be credentialing, they can be insurance, they can be just communication is difficult and how our systems talk to each other. The second big issue is really at the point that I entered this space, there was very, very few people doing this in pediatric hospitals. We did a survey in 2021 that looked at pediatric interventional endoscopists, and there was only 13 interventional endoscopists that would provide both endoscopic ultrasound and ERCP in the whole country. So there's not a lot of space. So there was clearly a need here to solve this problem. And I looked at this solution and really worked closely with a group in Texas, and we felt that producing an interventional endoscopy fellowship would solve this, where you can put a pediatric interventional endoscopy patient, somebody who needs interventional endoscopy services, with a pediatric interventional physician in the children's hospital, so we can reduce those barriers and remove those barriers. So this is where I got involved, and we started creating a fellowship with the group at Baylor College of Medicine, San Antonio. We created a 1-year dedicated interventional endoscopy fellowship that achieved kind of your classically defined adult volume for competency. We prepared the individuals for independent practice and confirmed that with quality metrics in the following years. And to date, we've now trained 7, I say we, I guess they now have trained pediatric interventional endoscopists, 7 of them who are scattered throughout the country. And it's really that model that now gives us this solution where we can kind of realize that solution to all those barriers. So that's a little bit about the history and how I got involved with interventional endoscopy. And so where are we right now? So the current state at Seattle Children's is really, like I said, it's very much the future is now. We're doing a lot of procedures that are, done in a handful of centers throughout the country, and being able to offer newer things as they become available to pediatric patients. And so to revisit what is interventional endoscopy, well, this is a long list, and all of these things are currently being done in Seattle Children's. So a lot of our work is in the pancreatobiliary space. So I'd like to highlight that with our first case, and then I have some non-pancreatobiliary cases that I'd like to highlight some of the things we're doing with about 3 more cases. So we'll get to a little bit more, less words, more video. So the first case I'd like to present is one of pancreatic duct stones. So this is to review some normal, an MRCP. It's got a normal bile duct, maybe a little bit generous, but basically normal. And this pancreatic duct here is very thin, very smooth, and slim, and they both go all the way down to right here near the duodenum where they drain at the papilla. And we can kind of reproduce this anatomy using ERCP, which is where we pass an endoscope put a catheter, inject contrast in these ducts, and this is another pretty normal one. There's no gallbladder here. This patient's had a cholecystectomy. But otherwise, the biliary tree is fairly reassuring, and the pancreatic duct is also reassuring, nice and smooth and small. So that's our starting point for normal for everybody to kind of get their bearings. And then I'm going to show you our first case. This is an 8-year-old with a variety of medical issues, bacterial TEF, duodenal atresia, annular pancreas, and he presents with acute recurrent pancreatitis and chronic pancreatitis with pancreatic duct stones. And this all started for him in 2021 when he started getting pancreatitis attacks. He started having attacks quite frequently. The standard workup was really normal, and so it was thought that likely this was the annular pancreas anatomy and the abnormal anatomy. This causes difficulty with the pancreas draining, and if your pancreatic enzymes turn on in your pancreas, the pancreas becomes inflamed and upset. So that was the likely cause for him. He had, as part of his workup, an MRCP, and there was a stone noted in a dilated pancreatic duct. At the time, this patient had to go to Colorado. So in February 2022, had an ERCP, had a sphincterotomy, which is where they cut that kind of muscle, the exit door of that bile and pancreatic duct system. They cut that muscle to open it up. They dilated the system to try to promote stone clearance. Unfortunately, they weren't able to get a wire into the system, and they weren't able to remove any stones. But fortunately, the patient did quite well. He didn't have any episodes of pancreatitis for almost a year, but unfortunately, in the spring of 2023, started having episodes every 2 to 4 weeks. And so at that point, I was here established in Seattle, and I saw the patient, and we ordered an MRCP. And this MRCP should not look like the other one. You should notice there's some differences, and I'll point out this is the pancreatic duct right there. Pretty big, lots of side branches and weird things coming off. But right here, there's like a filling defect. It doesn't go all the way to the duodenum like that normal did. All right, good. And so here in this situation, the goal is to relieve an obstruction. We want to do that. We get a wire past the obstruction into this deep area of the pancreatic duct. Then we can get devices into that system. We can use those devices to dilate the system. We can place stents to further dilate the system, eventually giving us a drainage path that, in addition to getting stones out, allows us to get devices in and address this stone and stricture for this patient. So we started doing these procedures in June, the first one in June, and we did a full evaluation. And again, for some normal, this is a normal normal papilla. In the side of the duodenum, you'll see this with the duodenoscope, and it's a muscle under here. It's a bulge with a muscle, and there's an os here that we can put a cannula in and get access to the bile ducts and the pancreatic ducts. So this is our patient. Clearly the annular pancreas, all this abnormal anatomy. He doesn't have a clear papilla the way patients normally do. We also did an endoscopic ultrasound, and more evidence that this is stone because it's a really dense signal that our sound waves can't get past this calcified stone. So we have shadowing in our endoscopic ultrasound. And we did ERCP, which showed a radiopaque stone, meaning it's an old stone on the scout film, and also abnormal pancreatic duct anatomy with a large dilation in the head and neck. Unfortunately, much like Colorado, I failed to access this system the first time. And so we had to switch gears and really offer a therapy that's not often offered in pediatric medicine in the GI space, which is called ESWAL. So again, to just review, the goal here is to get a wire into the system, to get it wire deep past this obstruction, to get devices, dilate, get stents in to further dilate, and then remove these stones and treat the strictures at this obstructed area. So in the fall of 2023, we started doing several ERCPs coupled with extracorporeal shockwave lithotripsy, which is ESWAL. This is something they use in renal stones to break up kidney stones. And our pediatric urology division really was a great partner. They helped us bring in the machine, and we were able to break up those stones over several sessions and work on them with ERCP coupled. So here's how this all went. Again, when we start off, we don't really have a great spot to work with, but we don't see where we're going. It's not clear. But we're able to get access, and initially we're able to get, after the ESWAL, we're able to get a wire pass, which is our first victory. You can see there's still abnormalities in that pancreatogram. Here there's an area we don't get great signal. That's either stone or stricture. It turned out to be both. We then, even though we couldn't get a device deep into the system, we were able to get a balloon into the very distal aspect of the pancreatic duct over here and dilate that. And then here you can see kind of now we have a working space that we can see our target. And then we keep going, and with further ERCPs and S-wall treatments, we're able to get now devices in, we're able to dilate more, finally able to get a stent in, which is a big victory because it really protects the patient from getting further episodes. And then as we continue on, the last procedure, we still have filling defects, we still have abnormalities here, and we're able to put a bigger balloon and really dilate to the point where now we can really see our target, now we can put stents in, and now we're getting stones out. So we're seeing these are stones, these white flecks, these are calcified pancreatic duct stones. We're able to get multiple stents in, really expanding that system. And it really allows me to illustrate kind of another interventional endoscopy intervention, which is pancreatoscopy. So pancreatoscopy is where we put a camera through the duodenoscope into the pancreas duct, which is very rarely offered, but luckily we have a great team here, and we're able to do it. So this is some video of us. Now this is a camera inside the pancreatic duct. You can clearly see those stones, clear as day, and we use a probe to do electrohydraulic lithotripsy, which creates a shock wave in a fluid bath, and it breaks up and fractures the stones so that they can become small enough to be removed from the patient. Yeah, it's very satisfying too. It's like a video game. So this is done in the bile duct often, but it's almost never done in the pediatric world in pancreas. So it's really cool that we have a kind of a can-do attitude here. So afterwards, we're able to use a balloon, and we're getting big chunks out now, and we're able to put that same camera back in and confirm that we have no longer any stone debris. So that patient now has no stones and has done very well. Really didn't have an episode of pancreatitis from the time we started doing our earlier ERCPs for about a year, and was having them every 2 to 4 weeks before. So. This is now going to transition from a case that's non-pancreatobiliary, which is now become a big part of our practice. So this is now G-tube closure. So we're starting to do this in young children. This is a 4-year-old with a previous G-tube, had it removed because it didn't need the G-tube anymore. Unfortunately developed a gastrocutaneous fistula and had surgical closure. And surgical closure works the vast majority of the time, but like everything, nothing's 100%. So this patient unfortunately developed a fluid collection and wound dehiscence where there was leaking of formula, and it got really bad to the point where we needed to replace the G-tube because of the breakdown of the area, tissue breakdown. So we replaced the G-tube, and the surgeons say, hey, could we try to close this endoscopically? And we say, yeah, there's a couple of different new devices, new techniques that we can try. So we use what's called a helical tack system. These are these little tacks that are on a probe that we pass through the camera, the scope, and they have a helix that we can kind of corkscrew and embed into the wall of the stomach. And there's 4 of these, 1, 2, 3, 4. They're all connected to the same suture, and you can imagine if we pull that suture and tighten them, they'll all come closer together and close the defect. So here is our case. We prepare the site with some argon plasma to kind of help promote wound healing after we bring it together. And then we embed these tacks. This is our second one. We can do either a Z pattern like the diagram, or I do a figure 4. And this is our final one, and you can really see the muscle. We get muscle layer when you start to see that corkscrewing of the mucosa, and we deploy that tack. And then we're going to pull everything tight and pull it together. And then we're going to advance what's called a cinch, and that really locks everything into that configuration and cuts the suture out. So you'll see that cinch go in. Approximate everything nicely, deploy the cinch, voila. There we go. So it worked really nicely. It doesn't always work really nicely. It's not 100% just like everything else, but we've had some good success cases here since starting doing that. And this patient, as opposed to kind of having that leaking area, has a really nice G-tube site here healing nicely. No more leaking. The next case I have is another kind of off-the-wall situation. I mean, it's not an uncommon situation, but we use a new device to help with an ulcer. This is an 11-year-old, had ileoatresia, which, is a blockage. We have to surgically resect that, so the surgeons go in and resect that. They anastomose the ileum to the colon, and at that site, sometimes there can be poor blood flow, and patients can develop an ulcer. This patient had iron deficiency anemia requiring blood transfusions, iron infusions, developed blood per rectum, fecal occult blood testing. So on colonoscopy, we confirm an anastomotic ulcer. And we do kind of the standard treatment, which is argon plasma. And that's going to kind of disrupt the vessels and hopefully stop bleeding and promote wound healing at that ulcer site. But after two treatments, he continued to have anemia. So we said, there's this new clip that we can try to use. The way the adults close a resection site after they resect a cancer, we can treat the ulcer. Here's the ulcer. First, we treat it with argon plasma. And now we're going to use our new clip, which is different from typical clips because we can open and close it and it will still hold the tissue. So we take it from the left, we go over to the right, and when I open this, if you had a different or an older style clip, that first tissue would fall off. This part would fall off, but you can see it's kind of nicely holds on, and so we can use that clip in that fashion and really covering healthy tissue to healthy tissue on each side of the ulcer bed, and it puts that ulcer kind of that was pre-treated in approximation and allows healing. So this is a colonoscopy plus probably 30 minutes. It's this is a kind of a standard clip, and that's so I just closing some small areas, and then I'll show one more example of this special clip. So we're grabbing healthy tissue here on the right. We're going to pull it over, and as you open it, you're going to see this stuff is going to stay still. It's going to hang on. And see, it's still there. And we can grab some healthy tissue here, close it. And at the end, we have now a protected ulcer bed. And I think I show a final shot. And I'll just say this patient then bumped their hemoglobin up 3 points and does never come back. So it's like a really satisfying thing to be able to offer that non-surgical. That patient may have been headed for a resection of that anastomosis. So the final non-pancreatobiliary case we'll look at is really kind of is really special because it really characterizes some of the multidisciplinary team work we have here at Seattle Children's. This is endoscopic vacuum therapy, and this is really championed by our esophagus team and our tracheoesophageal fistula team. So this is a 6-year-old with type C tracheoesophageal fistula who as a neonate had repair as a standard. Unfortunately, there was an esophageal anastomotic leak at that time. Our surgeons were caring for the patient. Our team was caring for the patient more recently, and the patient had tracheomalacia and a tracheal diverticulum. So after a full evaluation, underwent tracheopexy and diverticulum resection and repair in September. Unfortunately, due to that early esophageal anastomotic leak, it was very fibrosed and difficult surgical anatomy. So there was an esophageal injury and eventually an esophageal leak. And so here is some pictures of the initial leak. This is the esophagus kind of upstream, and then if I go down in here, that's downstream to the stomach. That's downstream to the stomach. And you can see this is actually kind of a perforation or leak. It's 2.5 or so centimeters, and this is pleura, and on the other side lung, and so it's it becomes a really tough thing because there's poor surgical options in this situation. So our esophagus team, the tracheoesophageal fistula and esophageal atresia team, working with Dr. Dellinger and Dr. Padamnuch, Dr. Pickens, and Dr. Kresalop, really decided to take again from the adults who use this in post-cancer resection surgical leaks, and it's done in a handful of programs in the United States, and they take this and use it for our patient population. And so this is really fun. Dr. Pickens creates this amazing sponge. He deserves a shout out because of all the time he puts into creating this sponge. And we really are going to connect that sponge, which comes from a wound vac, just your standard wound vac. and we're going to connect it to a Salem sump where we can put that sponge to suction and kind of make sure there's no leaking outside of the GI lumen. And so we first have to place the sump in the patient. So you can either do that, and a Salem sump is kind of like a big nasogastric tube. We can place it through the nose, and then we have to run it out the mouth, put the sponge onto the Salem sump, and then with an endoscope put it right next to the leak. Or in our patient's case, she has a G tube. We can go through the G tube and run the Salem sump up through the mouth, and then we can sew the sponge to the Salem sump and then pull it back and using a scope go down, and either way get it really approximated to the leak. So this is us sewing that short video. This is what it looks like afterwards. We have kind of this sponge. Dr. Pickens tries to make it about the size of the defect, a little bit bigger, so it'll cause granulation reaction at that area. And this is what it looks like when we're changing these sponges out. We have to do this 1 to 2 times a week. This is an old sponge. It's got a lot of secretion, cells. We take that out, and this is the esophagus like a week and a half ago. So really a lot better shape than it were. There's a little fistula we're still working on, but we replace a new sponge, and on we go. And this has really great outcomes in adults, and we're satisfied so far and still optimistic that this is going to be a good solution. So when we look at this under fluoroscopy, earlier in her course we had a blind pouch here and clearly a fistula. This is still that fistula that we're still working on. But about a week ago, this is much better. This is kind of more socked in. I think we still have some communication here, but you can see it's clearly better than where we started. So again, if you compare the two pictures, it's really satisfying. So now kind of the last part, a little meat and potatoes of the talk. The future is near, so it's not here yet, but I'd like to focus on endobariatrics. And if you'll recall, this is all the things we're doing. The future of interventional endoscopy, really, there's a couple of emerging areas. One is third phase endoscopy, which is dealing with premalignant lesions and achalasia. But today, I'd like to focus on endobariatrics because I think that has a very high likelihood to be very impactful in young adults and adolescent patients. So, there's gotta make it big. So why endobariatrics? And this is a controversial topic, but the reality is in the 1980s to now, we've had a tripling of our obesity rates in this country. And this is in the setting of essentially lifestyle modification, multidisciplinary lifestyle modification, exercise and diet being the cornerstone of what we had to offer. And the issue with that is that children with obesity and adults with obesity have downstream comorbidities that really affect every organ system in the body, and every provider sees this. So whether it's even mood disorders with depression, anxiety, heart disease, cancer risk is increased, diabetes, and in our world, in the GI and liver space, we really have liver disease or non-alcoholic fatty liver disease. And this is not improving. The forecast for both pediatrics and adults show that this is going to increase in the next 5 years significantly, especially in the adults when you look at when you look at diabetes. And if we just want to talk about dollars and cents, diabetes alone is really stressing the U.S. healthcare system. This was now 5 or so years ago, and $1 out of every 4 healthcare dollars was spent on diabetes and its downstream effects, to the bill of about $327 billion annually. So this is not sustainable, and it needs to be addressed and kind of have new ideas. And I think that's happened in the adults. And from a standpoint of a GI doctor or a liver doctor, why endobariatrics? Because we see it. I used to see more, this metabolic associated steatotic liver disease. It used to be called NAFLD, or non-alcoholic fatty liver disease. They had a name change. And this is increasing. In 2009, there was only 36 cases per 100,000 kids. A decade later, 2018, it's up to close to 60. So MASLD is clearly rising. And it's not a disease that we can really always see when they've crossed the threshold. So this is a mentor of mine's patient, a 10-year-old in 2009, and any pediatric provider probably has seen ALT of 160s, AST 60, GGT. It's not normal, but it's not 600. And we trend these patients, and 2 years later, the patient has, definitely increased, but it's not 400, 500, 600 for these ASTs and ALTs. So really, you would kind of think maybe this is a stable patient overall. But when we look at the biopsies, this liver, when taken at 10 years old, was stage 1C fibrosis, but with really little biochemical changes. There was some waist circumference changes, but biochemically it was fairly stable. Now we have stage 3 fibrosis with bridging fibrosis and really on our way to cirrhosis. And why do we care about cirrhosis? Of course, well, cirrhosis itself is bad, but in young adults now, this is the most common cause for transplants, for liver transplants, for young people in the United States. So really, why endobariatrics? Because obesity is a serious problem in children. It affects every organ system, essentially, including MASH. And young adults are having liver transplants due to this at an alarming rate and trend. And these issues are reversible with weight loss. So it's really important to understand that if you have MASH or MAFLD, that the data shows that about a 7 to 10% weight loss can reverse the trend and sometimes resolve the fatty liver. So this follows for all the comorbidities. Heart disease can resolve and improve, joint disease, etc. So how do we do this? Surgery, intragastric balloons are used. Medications are obviously a huge topic of conversation. The old standby lifestyle modifications, and I would say yes, 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 and yes. Everything needs to be employed. This is a diagram that looks at the obesity treatment pyramid. This is for adults as far as the cutoffs, but the point that I want to make is that the new way of thinking about treatment for patients with obesity is to offer a menu of options, a variety of options, because one size does not fit all. The medications are great, but they're not perfect for one person. They may be great for another. The surgery is excellent for somebody, but not for the next person. So I think we need to come up with a lot of different options, and I think we need to consider combination therapies, and we all use these new treatments to really get traction on the lifestyle modification. The lifestyle modification, healthy diet, exercise that never goes away. These new therapies just allow them to be maybe a little bit easier and allows them to have a lot better traction when the patient does buy into those. So endobariatrics and pediatrics. Really, this starts from kind of the trend of bariatric surgery. So in the past, they would do what's called a Roux-en-Y gastric bypass, and in adults they still do this. This is a really aggressive surgery. It reroutes a lot of the GI tract, and for children this is not favored. There used to be the gastric lap band. That's now not indicated off the market for weight loss. So what is the workhorse for pediatric bariatric surgery is the vertical sleeve gastrectomy or the lateral sleeve gastrectomy. But this lateral part of the stomach is surgically removed, and their resulting is a sleeve anatomy where there's not much space for food and people get full easier, et cetera. It delays gastric emptying. And so in endobariatrics, the idea, and I'm going to explain what I mean by endobariatrics, I'll show the procedure, but really this is what we're going for. It's a replication of that anatomy. And all of these things have good parts, a lot of positives, there's downsides to all of these, but I want to highlight a couple of the positives of endobariatrics. It's a procedure that goes through the mouth, so it's incisionless. It has some short-term reversibility, so you can cut the sutures a few days later, but almost nobody does that. Has very, very favorable adverse events. Most of the issues are very mild, and they go away within a week or so. Much shorter recovery than a lot of the surgical treatments, which is kind of the big advantage. Most adults will have it on a Thursday or Friday and be back at work on Monday. So there's no scars. People can go back to school and kind of not have their friends, know they've been out of school for like 2 weeks dealing with something, so that's good. And really, it doesn't burn any bridges. You can still have a surgery if you'd like. You can still take the GLP agonists and be okay. So those are some of the positive aspects of endobariatrics, and the societies are getting on board slowly. So in 2018, the American Society of Metabolic Surgery really recommended that patients with these comorbidities should be considered a strong indication for metabolic surgery in adolescents with severe obesity. That's the surgeons. They don't make a specific recommendation on endoscopy, but now bariatric endoscopy should not be denied based on age, is what they say. The liver disease, focusing on NAFLD and NASH, the AASLD, has no real recommendation on bariatric endoscopy, but bariatric surgery can be considered in otherwise eligible obese individuals with NAFLD or NASH. And then the big one was when the American Academy of Pediatrics in 2023, they recommended referral for adolescents age 13 and older with severe obesity and comorbidities for evaluation for metabolic and bariatric surgery. At this point, there was no clear recommendation for bariatric endoscopy, but I'll kind of talk about it later. There's an international federation that's essentially including bariatric endoscopy in their recommendations, and there's more endorsements every year coming out. So now, what is bariatric endoscopy? Really, bariatric endoscopy or endobariatrics is endoscopic sleeve gastroplasty. It's recreating that sleeve configuration. This is our gastroscope. It's a device that goes on the tip of the gastroscope to do endoscopic suturing. This has a little helix here where we can, kind of like that helix we used for the closing of the device, we can grab tissue and we can pull a piece of the stomach in, and this jaw can put a suture through, a full thickness suture through the stomach wall. And the way this works is we kind of start at the antrum and we do 3 there. And then doing these, we're going to, again, this is kind of what it looks like. We're grabbing tissue with that helix, pulling it in, that needle goes through. And then we move back and we do another line of 3. And then we use that same cinch that we used for the helical tack system to kind of tighten those up. It brings everything closer together and we lock it in place. And then we do that several times throughout the gastric body and kind of the lateral and inferior wall, and we get a sleeve configuration at the end. And it takes about an hour to do. So what about the data on ESG? Well, this is the landmark 2022 MERIT trial, multi-center, prospective, randomized crossover trial in adults for class 1 and 2 obesity. And this was a resounding success. It demonstrated that if we look at total body weight loss, remember I was saying 7 to 10% is kind of goal to resolve a lot of these comorbidities. This procedure is getting about 14 or 15% total body weight loss in adults when compared to lifestyle modification. Lifestyle modification, unfortunately, doesn't on its own have a lot of traction. But the patients, like I said, a crossover trial, so at a year, these patients that did the lifestyle arm were offered the procedure, and those patients also went right up to 14%. What about comorbidities? This is a busy slide, but I'll just want to make sure I just kind of simplify it and summarize it. This is comorbidities with this trial. It's basically effect on any comorbidity that the patients had. 80%, I don't know if you can see this, about 78-80% had improvements of at least one condition. So that's pretty good. Very excited about that. So a little bit more on the ESG from the MERIT trial. This is their adverse events profile. So they did have an abscess and they had a bleed. Those resolved without intervention, but they did have those too. And this was about just under 150 patients having this. Whoops. I want to go back and I want to highlight these are the most common side effects. And just to simplify it, it's kind of abdominal pain, nausea, and vomiting. And the vast majority of these bars are mild, moderate, and there's a tiny bit of severe. And this is less than 1 week after, so they're going to have symptoms. It's essentially replicating a fairly good surgery, big surgery. But very quickly, within a week and definitely within a year, this is only a handful of patients, under 5-10%, where you're getting any kind of mild symptoms after the ESG procedure. What about durability of ESG? That's new data. It's now coming out. Some of the earliest studies are showing their patients are now kind of getting to the 5-year mark. So we have data at 5 years that shows maintained durability of the procedure. So these patients are losing the weight and keeping the weight off for at least 5. Now, a little point on this. Patients can this will fail in the wrong patient. Surgery will fail in the wrong patient. GLP-1As will fail in the wrong patient. A patient can overcome all of these therapies. So that's why it's super important for us to kind of make sure we have the right person with the right procedure so that we get success and prolonged success. This is the most recent societal recommendation. This is the International Federation for the Surgery of Obesity and Metabolic Disorders. This is a humongous international conglomerate group that has mostly bariatric surgeons and some endobariatric specialists as well. And they put out it's really a systematic review, or actually, no, they call it evidence-based review and position statement endorsing endoscopic sleeve gastroplasty for the treatment of obesity. And in their review, they again show 5-year, this is, I don't know, again, hard, but this is 60 months, so 5-year data, and that dark orange bar is still kind of maintaining at that 14, 15. And here, if you're not a bar graph person, it kind of peaks at 1 year about almost 17.5% total body weight loss, and then at 5 years, still at about 16% total body weight loss. So very, very good data for patients. And then what about, as a GI doctor looking at MASLD? This has been looked at with another group. And this group looked at non-invasive markers of NAFLD, because you can't do biopsies on everybody all the time. So the non-invasive, everything, this is a mean difference. So everything goes down, and those are all fibrosis scores and indirect biochemical markers for metabolic syndrome and NAFLD, and we want them to go down, and they all go down. And then where I think we'll go is the newest data is kind of the combination of this procedure with the GLP-1 agonist. So this shows, and the gestalt here is this on the right, these red and orange are going to be combination with ESG and the GLPs when compared to just the ESG. And you can really see, the red graphs are going to show a bigger drop. And that's for weight loss, the red is lower, and then for metabolic markers, again, also hemoglobin A1C goes down quite a bit, more with GLP if you add it. So I think that's where the trend in the science is going, is combining this with GLP-1 agonists. And so you might say, like, well, what about kids? This is all in adults, almost all adults. Well, there's a pretty big series in Saudi Arabia where they started to do this on children. And most of the adult centers have done a handful of people under the age of 18, but there's not been a U.S.-based trial to this point. But the Saudi group, they looked at 109 consecutive children and adolescents with obesity. They did a 2-year look at this, and really, it's pretty similar to the MERIT trial. This is the 1-year data, 16.2% total body weight loss, and the 2-year data, there was only like a handful of people that were at the 2-year mark. But I think it was 13.5 or 13.7. So it's pretty similar in children, at least in this early Saudi study. But one thing this Dr. Al-Qahtani did very well is I think he introduced, or this is where I heard about it, is they introduced the idea of this multidisciplinary pediatric interventional weight loss flow sheet. And this is kind of the basis for where we're going with a metabolic multidisciplinary program here, and where they're going. Essentially every top children's hospital in the nation now is developing a program or has a program like this, where the patient comes in, and not to go into the nitty-gritty details, but they're evaluated by nursing, by psychology, and they're initially kind of evaluated by the whole group. They're given a lifestyle modification, and depending on how they do, the whole group meets and says, what is appropriate based on the parameters and what we know about this patient. And as a group, surgeons, metabolic endoscopists, endocrinology, psychology, nutrition, all meet together and have shared decision making on what probably the offering should be. Like, maybe this patient's not right for this thing, but these two things would be good. And so he does that in his clinic in Riyadh. And that's really kind of the goal we have here, is to establish the Seattle Children's Metabolic Weight Management Program that takes in information from endocrinology and their expertise in the GLP-1 medications, psychology, obviously, nutrition, obviously, because this is all here to make sure we make a good shared decision with the patient and all the vested parties, so that we can offer what is going to be most likely successful for that individual patient. And so I hope that very soon be talking to you more about that. At this point, I'd like to say thank you to everyone who's involved with our endoscopy group. I'd like to say thank you to our division chief, Evelyn Sue, for really championing our endoscopy practice, Dr. Walker Harding for supporting it at the departmental level, and really our scheduler, Jolie's on here, and most importantly, our endoscopy nursing, Wakara Weiss and her group do a wonderful job. They have a can-do attitude that allows us to kind of not skip a beat when we bring in some weird new device. And so, all right. And otherwise, I'd like to open it up for questions.
Wow. Incredible work. Thank you so much for all of this. I'll open things up first to questions in the room, and then if you're online, you can type your question for me in the chat.
Thanks, Jeff Ogerman. Thank you very much for this, for deciding to come here and successfully building all this. I wanted, as somebody who remembers the 90s, I wanted your insight on how something evolves into, how a field evolves into a pediatric subspecialty. Because what you'll see is this evolution of, there's a few groups that start to realize that there's a way to care for kids differently. And then it slowly gets bigger, and then there becomes this real inflection point where there's some pros to subspecializing, but also the risk of losing the expertise of the broader field, and especially for diseases that don't look a lot different at age 17 and 19, there can be some some challenges.
I think that's an excellent. Thank you for the question, Dr. Ogerman. I think really when we start to see these really specialized programs, it's a situation where interests align, where we have people who are really interested in making this the focus of their career, and we have institutions who have an issue. So I think when we can have institutions have a problem and a individual who wants to really make that the focus of their career, it makes a lot of sense to specialize. Of course, as you get more specialized, you do lose some of that broader knowledge, but I think the individual's already made that decision. It's really when it can be paired with an institution that sees the benefits. And so in this case, there's a lot of benefits to developing a specialized endoscopic procedures, because we now can draw from all 5 states and offer it to not just children locally, but we're providing a service that otherwise becomes quite a burden on families. But I really think that where the rubber hits the road is when there's a aligning of interests at the institution and finding that individual who wants to do the same thing.
Molly Groh, thank you so much for this fantastic talk and great work. It's so exciting to know about what's ahead. I'm actually interested in, as a primary care physician, caring for children that are facing some of these diseases as you're describing, the opportunity to offer these procedures, the endoscopic bariatric option for children that have special healthcare needs, and including cognitive disabilities. Mm-hmm. What is that looking like? Has that been used in any setting yet, and is that a potential for us?
Yeah, thank you, Dr. Grove. I appreciate that question. Good question. So, with regards to where we are with actually offering the procedure for the community, I think we are very close here, and there's a handful of places that are very close. There's nobody that's currently doing it in the United States, other than a couple of one-offs for the adult practice. There's some barriers. There was more barriers a year ago, but the FDA just gave a CT code, a CFT code. What am I saying? What am I trying to say? CPT code for Class 1 CPT code for the procedure in adults. So that's very helpful. The industry partners have helped advocate to kind of do the prior authorization. So there's a program there. That to date has not been offered for pediatric patients, but we're working on it. And so I think we're close. I think within the year, somebody will start doing this. There's not a lot of people who are trained in it, so that's the one thing about here is I've gotten training in the procedure in India, but the barrier here really is if we're going to do this right, it really needs to be done under a research IRB, and we need to get an investigational device exemption from the FDA and all these things to do it in pediatrics. And so that is a lot of work, and I am one. So if anybody has any research interests and help, I'd welcome it. We can definitely talk.
Thank you. Yes, that's one of the reasons we brought you here, actually, so that people can hear what you're doing and see if they want to collaborate. And my question is similar. How many years away do you think we are from having that multidisciplinary weight management clinic here at Children's? And what do you need from all the people who are listening to this talk to make that a reality?
Well, I mean, I think we could do it as soon as we get an IRB and an investigational device exemption. So to get the IDE, you have to have an IRB. Which is, certainly dependent on the speed at which we do it. So we're working with Mason and our GI research, and Melissa, our research colleagues here, to try to get kick-started. But yeah, definitely welcoming any collaboration in this space, because I think at this point, that's really the bottleneck.
Melinda Pierce, Pediatric Endocrinology. I'm one of the medical co-directors of the Insulin Resistance and Type 2 Diabetes Clinic. We do have a multidisciplinary clinic here through the endocrinology division, and one of our providers is a link, or two of them are a link to the adult bariatric program at the University of Washington. So this is available in some form, not endobariatric surgery, but kind of the multidisciplinary care aspect of lifestyle management is definitely already here. And to your question about intellectual disability, that's actually spelled out in kind of the bariatric guidelines, that should not be considered an absolute limitation, but just requires greater consideration, often a evaluation of the patient's understanding and ability to assent to the procedure, and the family's ability to care for them afterwards.
Thank you so much, Dr. Piester, and everybody for your contributions here, and we look forward to seeing what you're going to do next. Thanks so much.